Yeah, soon we are going to finish. I think it will take, it will go up till 8 p.m. and then we will revise it. Today we will be able to revise only we will only able to revise only the oncology MCQ. Okay, Dr. Rachna. So, is the audio video clear? Can we restart? Okay, can we restart? Oncology will go up till 8 p.m. and then we will revise the MCQ of oncology. Contraception we will do tomorrow. Okay? Okay, yes. Let's start it. We were discussing the vaccine pap smear. Okay? So, vaccine. The 3 questions which are expected from the vaccine are, come on everybody, what happens we do the vaccine and then the question comes from vaccine and we are not able to do it. Okay, let's start it. First question which is expected from the vaccine is, will we do the pap smear after vaccination? Yes or no? Will we do the pap smear after vaccination? Yes, we will do, because 100 serotypes are there which are causing CA cervix. Vaccine is protected only against maximum 9 serotypes. Okay, vaccine is only protected against the 9 serotypes. Is it okay? Okay, so we will always do the pap smear even if the vaccination is done. Okay, number second question, can we give this cervarix or what can CA cervix vaccine to pregnant patient? Quite often asked by FMG examiner, can we give the CA cervix vaccination to the pregnant patient? Yes? No. Which are the other 2 vaccines which we cannot give? Varicella and MMR. Which are the other 2 vaccines which we cannot give? It is varicella and MMR. Okay? Live vaccines cannot be given. Another question. What is the target age? What is the target age? The target age is 11 to 12 years. The target age is 11 to 12 years. Okay? Very good. Now you tell me there are 3 types of vaccines. Cervarix is bivalent. Very good. Cervarix is bivalent. Which population does the which serotype does the cervarix has? From which 2 serotypes does the cervarix protects? Yes. Answer is 16 and 18. Don't mark in the question 6 and 11. The answer is 16 and 18. Gardasil is quadrivalent. It is again 6, 11, 16 and 18. And Gardasil 9 is nonavalent. Other than these 4, it is 31, 33, 45, 52 and 58. Okay, Gardasil 9 is nonavalent. Very good. What is the dosage? This is the new. This is the new. The one which is highlighted in yellow is the new SAGE guidelines. Okay, SAGE guidelines, and the other one are the old guidelines. As per the new guidelines, in less than 21 year, we will give 1 or 2 dose. So if the word SAGE is written there, then you have to say this, and if the word SAGE is not written there, then you have to follow this. Okay, so you have to look for the word SAGE. If in the less than 21 years, we have to give 1 or 2. Okay, or word is there in between. Okay, because they are proving to be of same efficacy. And more than 21 years, we have to give 2 doses 6 months apart. Okay. Okay, already in INS set they have asked this question. So if your examiner look that INS set paper, then he can ask you. Okay, if the vaccine is if we don't follow the SAGE guidelines, then less than 14 years we have to give. Come on, everybody. Less than 14 years we have to give 2 doses, and more than 14 years we have to give 3 doses. Accordingly, you will adjust yourself. Okay, let us see the screening guidelines. Screening is done in all those patients who have 0 symptoms and healthy cervix. Screening is always done in non-symptomatic and healthy cervix. Screening is not done. Okay. Dr. Kavita, I'm not getting your question. Please write again. Okay, screening. There are 3 screening methods: Pap smear, VIA, and villi. Pap smears, you all know. VIA stand for visual inspection of acetic acid. Target means that target population age that we want, in which population to be given. VIA means visual inspection of. Yeah, these days, Dr. Mohit, males are also being vaccinated. Okay. VIA means visual inspection of acetic acid, and villi means visual inspection of locules iodine. Most cost effective is VIA. Okay, I have been the member of CA Cervix Protection of the Punjab. Okay, so I know that the most cost effective is VIA. The nurses are being trained for this method, no doubt, because the gynecologists and pathologists were not available with the civil in the hospital. So the government has started the cost effective VIA. In the VIA, we don't need any doctor, only nurse can do that procedures. So the cost effective is VIA. I know that government has spent large amount of money and large amount of time, and being had, I can assure you this, no controversy in here. Best standard screening method is Pap smear. Okay, WHO recent guidelines for the screening. Please, from the last 1 year it has been changed. Please focus here. If in your question it has been written WHO developing, WHO guidelines for the developing countries, then these are the guidelines. Okay, last 1 year it has changed. Okay, it is the screening population age is 30 to 50 years in the developing countries, beta. Okay, in the developing countries it is 30 to 50 years. Okay, HPV testing is best. If it is done, then the gap between the 2 HPV testing is 5 year to 10 year, and in the VIA and PEP, if it is done, the gap is 3 yearly. Okay, 3 yearly. And in the developed country, if the developed word is there, then that was what we were earlier studying, 21 to 65 years. From 21 to 29, it is PEP 3 yearly. PEP 3 yearly. After 29, if the patient can afford HPV, then it is to be done 5 yearly. And if patient cannot afford HPV, then it is the PEP 3 yearly. Okay, so only you have to learn the target population has been changed as per WHO for the developing and for the developed countries. Developed country was that which we were early studying, 21 to 65 years. Okay, but for the developing countries, it has been changed to 30 to 50 years. If the word developed is written, then you can understand that your examiner is asking something new. Okay, steps of pap smear. First of all, the vaginal wall is put, all of you see in the camera, the vaginal wall retractor is put, okay, and we observe the cervix, and then we scrap the transformation zone, and then we take the cells and we put it on the slide. Okay, immediately we have to take precaution not to air dry. Not to air dry. Immediately we have to put. Okay, fix the slide with, and then we have to apply fixator. We need not to fix it with air. We have to, come on, tell me, what is the fixator used? 95% ethanol. 95% ethanol. Okay, 95% ethanol. But how we will interpret the pap smear report? You all will tell me. As per Bethesda classification, there are two groups, LSIL and HSIL. High grade squamous intraepithelial lesion, low grade squamous intraepithelial lesion. As per cervical dysplasia classification, there are 4 grading, CIN 1, 2, 3, CIS. CIN 1 means only 1/3 of the epithelial cells are involved. CIN 2 means 1/3 to 2/3 of epithelial cells are involved. CIN 3 means more than 2/3 epithelial cells are involved. And CIS means cancer in situ. All the epithelium is involved. As per Bethesda, LISL is equals to CIN 1 and HSIL equals to CIN 2, 3 and CIS. Is it okay? Is it okay? Okay. If in the report it is given ASCUS. What is ASCUS? Atypical squamous cell of undetermined significance. Pathologist is not able to tell that whether they are of importance or not. Pathologist is not able to tell. Okay. Okay. So if the report is ASCUS or LISL or CIN1, they are one and the same thing. Okay. Then what you will do? If the reporting on the pap smear is ASCUS, LSIL or CIN1, we have to repeat the pap after 6 months. When we repeat, usually we repeat it after 3 years. Okay, but when CIN1 comes, then we have to repeat the pap and undergo HPV testing. Okay, undergo HPV testing, right? Okay, and if the reports comes of CIN2, 3 or CIS, then the next step is colposcopy biopsy. Okay, colposcopy biopsy. Will you do punch biopsy? No, because screening is not done in the unhealthy cervix. In unhealthy cervix, we will do the punch biopsy directly. Pap smear is not done in the unhealthy cervix. Okay, why we do colposcopy biopsy? Why we do colposcopy guided biopsy? Colposcopy guided biopsy is done to find the lesion. Colposcope help us to find the lesion. So that was all about the screening. Okay, screening is finished here. Screening is only done for CA cervix. Is it okay? Now we are sitting in OPD and now patient is coming And now we will differentiate that whether which cancer is there. How does the CA cervix patient come to us? Now no normal patient. Now symptomatic patients are coming. Now in OPD we have to catch the patients. How the CA cervix patient will come? What is the age? 21 year to 65 years age, beta. That is why we are doing pap smear in that age. Okay, 21 years to 65 years age. What is the most common symptom of CA cervix? The most common symptom of CA cervix. Expected question and more specific symptom. DNA HPV, beta. DNA HPV testing. Okay, we find the DNA in the cervical epithelial cells. Dr. Isra is asking what is the name of the HPV testing. Okay, so what is the age? 21 to 65 years. The most common symptom is irregular bleeding because the cervix grows like a growth, and the most specific symptom is postcoital bleeding. Okay, most common symptom is irregular bleeding. And what is irregular bleeding known as? Metorrhagia. Metorrhagia. And what will you see in the examination? In the OPD, you will do examination. You can see a unhealthy cervix or the cervical growth. Is it okay? Very good. What you will see in what is the age of CA endometrium patient? What is the age of CA endometrium patient? Postmenopausal, 55 years to 65 years. They are not of early age. Okay. What is the most common complaint? What is the most common complaint? And what is the most specific complaint of CA endometrium patient? Most common complaint is menometorrhagia, irregular bleeding and heavy menstrual bleeding. Because there is endometrial hyperplasia, so there occurs menorrhagia and metorrhagia both. Okay, and postmenopausal bleeding. Is it okay? Very good. The tumor ovary. The tumor ovary. What is the age? There are two ages for the tumor ovary. One age is 55 years, or you can say postmenopausal age, in which the epithelial cell tumors occur. One is 0 to 25 years age, in which the germ cell tumors occur. Okay, what is the complaint of the patient? There is a ovarian mass. So patient complains of pain abdomen, large adnexal mass, sometimes ascites, and we confirm that mass on PV. After suspecting the patient, if the patient comes to us with irregular bleeding or postcoital bleeding, then we will rule out the CA cervix risk factor. The next our duty is to rule out the CA cervix risk factor. Okay, CA cervix, as we have studied, it occurs due to HPV, human papilloma virus, which is a sexually transmitted diseases. So we will inquire about its sexual activity. Okay, we will inquire about the age of the first intercourse. Age of the first intercourse. When was the first child? More early is the age of first intercourse, more are the chances of CA cervix. More early is the first child, more are the chances of CA cervix. Multiparous, more are the children, more is the sexual activity. Multiple partner. Of course, low socioeconomic status, immunodeficiencies, and STDs are also the risk factors. What was the complaint of patient of CA endometrium? In which symptoms you will suspect CA endometrium? Can you write down in the chat box? Menometorrhagia and postmenopausal bleeding. Okay, so So, what are the risk factor? All the factors which will increase the proliferation will be ruled out. Increase the endometrium proliferation. Okay. Here, two questions you have to ask. Two things you have to learn. Question will come from these 2 points. Tamoxifen and granulosa cell tumor. Okay. Tamoxifen is estrogenic. Tamoxifen is basically a SCRM. Already question has come in the June 22 exam. Again, it can be repeated because it is very important. Tamoxifen is anti-estrogenic on breast. CA breast patient takes them, and it is estrogenic on endometrium. So CA breast patient, if it is a very good drug of CA breast, is prone to endometrial cancer. Okay, they are treating one cancer and they are getting the another cancer. The tumor is granulosa cell tumor, because granulosa cell tumors synthesize estrogen. Okay, will you remember these two things? Will you remember these two things? It will be asked in the exam. Okay, tamoxifen and granulosa cell tumor. Okay, now endometrial proliferation decreases. There is no endometrial proliferation during the pregnancy. Sure, sir, I will do it. I will do it in the last of the class. Okay. So endometrial cancer, there is no endometrial proliferation and during the pregnancy and during lactation amenorrhea. So the nulliparity is the risk factor along with early menarche and late menopause. What is the genetic? They are asking lot of question on ovarian cancer genetic. They can ask on endometrial cancer also. What is the genetics involved? Which syndrome is genetically involved in CA endometrium transmission? Can you tell me? Can you write down? Lynch syndrome. Don't confuse it with BRCA1 and BRCA2. They will give in options BRCA1 and BRCA2. BRCA1 and BRCA2 are related with breast and ovary. Okay. The Lynch syndrome is related with endometrium and colon cancer. The another name of Lynch syndrome is HNPCC. Okay. Highest association. Will you remember it? Will you remember it? What was the complaint of CA ovary patient? You were sitting in the OPD, a patient come to you with pain, abdomen and abdominal mass. On the PV, you suspected it is a tubo-ovarian mass, adnexal mass. Okay, so CA ovary is highly linked beta with BRCA mutation. If BRCA mutation is present, BRCA1 and BRCA2 are present, what is the chance of the female that female will have ovarian cancer? Can you tell me in the percentage? Can you tell me in the percentage? What is the chance if a female has BRCA1 and BRCA2 mutation? What is the chance of the female to have ovarian cancer? It is 50%. It is 50%. In such a high chance, you will never do screening. Okay. How you will suspect that patient is having BRCA1 and BRCA2 mutation? You will suspect if there is history of ovarian cancer, breast cancer, or if there is history of ovarian cancer and breast cancer in first degree and second degree relative. Dr. Kavita, it is 20%, it is 50%. Okay. Depending on if BRCA1 or BRCA2 what are involved. Okay. 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 Tell me Which has higher chances, BRCA1 or BRCA2? If in the option both are given, BRCA1 and BRCA2, and they ask you highest chances are in which, what you will write? BRCA1, 1. Okay, BRCA1. Okay. Now a patient comes to us with ovarian mass. Okay, or patient automatically comes to us with complaining that my mother and my sister has it. Then what you will do? If a patient comes to us in OPD complaining that my mother and my sister has ovarian cancer, what you will do? You will get the BRCA mutation check. Okay, you will get the BRCA mutation check. Okay, you will get the BRCA mutation check. And if BRCA mutation is positive, then what you will do? If BRCA mutation is positive, then you have to do bilateral oophorectomy maximum after 35 years, because the ovarian cancer comes in 40% of cases. Bilateral after 35 years, because ovarian cancer comes after 40 years. Is it okay? Okay. Now, this was the main factor which was responsible for the CA ovary BRCA mutation. Okay. So, if a patient comes to you with a history of breast or ovarian cancer in very early age in relatives, then you will get the mutation checked and you will remove the ovaries and ovaries after 35 years. Okay. Now, if the epithelial now there is a major category of epithelial ovarian tumor. Epithelial ovarian tumor are directly proportional to the how much ovulation has occurred. More is the ovulation occurring, more the epithelium ruptures, more the epithelium works. So ovulation occurs with early menarche, late menopause, and in nulliparous lady there is no rest of ovulation during the pregnancy and during the lactational amenorrhea. Here the main factor which you will learn is infertility and ovulation treatment. Infertility and ovulation treatment. So what you learn in CA endometrium, what you learn in CA cervix, can we sum up it in one slide? What you learn in CA cervix? All the risk factors are related to sexual activity. Okay, in the in the CA endometrium, all the risk factors are related with increased endometrium proliferation. Okay, so which are the two risk factors on which question will come in exam? Tamoxifen and granulosa cell tumor and Lynch syndrome genetic inheritance or HNPCC. Okay, and in CA ovary, foremost is the BRCA mutation. Okay, foremost is the BRCA mutation, and for the epithelial ovarian tumor, foremost, which you have to learn, of course ovulation you will learn, foremost you will learn the ovulation or ovulation induction, or you can say infertility treatment in patient language. Will you learn these things? So we have summed up the slide in 3 lines. CA cervix risk factors are related to sexual activity. CA endometrium is related to increased endometrium proliferation, tamoxifen and granulosa cell tumor and Lynch syndrome. CA ovary is related with mainly with BRCA. Epithelial ovarian tumors are related with ovulation induction and infertility treatment. Is it okay? Okay. Now you have ruled out the risk factor. Patient has come to you OPD. What you will do? Now you will confirm your suspicion by the confirmatory test. What is the test? In a confirmatory test in CA cervix patient, it is if on the examination, on the cervix examination, if you are not able to see any growth or lesion, then you will do colposcopic guided punch biopsy, because you are not able to see any lesion. Okay, because you were not able to see any lesion. Patient of CA cervix come to you in the OPD with irregular bleeding or postcoital bleeding. You rule out the risk factors, asking her the sexual activity. Next, you confirm your confirm your diagnosis with the confirmatory test biopsy. If you are able to see any lesion on pars speculum on the cervix, then you will do colposcopic guided punch biopsy. With the help of the colposcopy, you will find the lesion. Okay, because you cannot send the whole cervix. You cannot ampute the cervix and send the whole cervix for the biopsy. Okay, you have to find on the cervix from which side you will take the sample. So you will find with the help of the colposcopy. Okay, if the lesion is visible to you, then of course you will directly do the punch biopsy. Is the things clear? In the endometrial, in the CA endometrium, what you will do? Endometrial biopsy. It can be office biopsy, then by the endometrial aspiration biopsy by the Pipli, or you can do hysteroscopic biopsy, whichever suits you. In the patient of ovarian tumor, you will confirm your ovarian mass finding with the help of the ultrasound, and you will get the tumor markers done. Soon we will study tumor marker. What are the findings for the benign lesion and malignant lesion on ultrasound? The benign lesions, they are unilocular and anechoic. What do you understand by anechoic? They are completely black. Okay, on ultrasound, unilocular and anechoic. It is very important. Basic things are target of FMG. And on ultrasound, how you will differentiate benign and malignant? You will see that in ovarian tumor, we do biopsy during the surgery, during the staging. Till then, we cannot know that whether the tumor is benign or malignant. We keep saying it tumor. Okay, we don't know whether the tumor is benign or malignant till surgery. So only the ultrasound help us. Okay, so malignancy sign is it is solid, thick septa. Anechoic means it is fluid. It is complete black. So if it is solid and if it has thick septa, papillary excrescences, increased blood flow, enlarged lymph node. These are the sign of malignancies on ultrasound. Okay. Now, how do we do colposcopic guided punch biopsy? Come on, everybody. How do we do colposcopic? We were not able to find the lesion. We have to find the site. We do it in 4 steps. First, we get the magnified view. On magnification, if we will get the ulcerative growth. Second is we will apply Schiller iodine. Okay, we will apply Schiller iodine on the cervix, and if there on the malignancy site, Wherever there is malignancy, they will consume malignant cells. They have to rapidly divide. They will consume all the glucose, so it will not get stained. Okay, the malignant site will be mustard yellow. Can you tell me which is mustard yellow color? This is mustard yellow color. Okay, if glucose is present in the cell, then what is the color of the cell? If the glucose is present, then the color of the cell is mahogany brown. This is the color. If the glucose is absent, then it is the mustard yellow color, because in the malignant cells, the glucose is absent because they have utilized it for division. So we will see this color in the malignant site, that is decreased glucose. Okay, and when we will apply the acetic acid, because the malignant cells contain increased protein, so we will see the aceto-white area. The malignant cells, the rapidly dividing cells, they have increased amount of DNA and RNA, which are basically the proteins. So we will see the coagulation of protein by the acid, and we will see the white areas. On applying the green filter, we will see the blood vessels. How are the blood vessels look? Question has come on the color of the filter. On the fourth step, we will apply the green color light on the cervix. We will put the green color light on the cervix. Okay, then why do we put that light? Because on putting the green color light, the blood vessels, the rapidly dividing cells, they have neovascularization. Okay, they have neovascularization. The blood vessels, they look as white colors. They look as white color lines. Okay, now wherever the lesion is seen, there we will do the punch biopsy. Punch biopsy. Is it okay? Now let us classify the ovarian tumor. Direct questions are coming on ovarian tumor classification. The outer epithelium is known as epithelial cell. Okay, the tumors derived from the epithelial cell are epithelial ovarian tumor. Okay, so epithelium or the outer covering is directly in touch with many organs in the peritoneal cavity. Okay, so it get influenced. So if in the ovarian mass serous fluid is there, it is known as serous. Okay, one thing I would like to tell you, the most important things are written here. Epithelial ovarian tumors, they are most common of all the tumors. Okay, they are most common of all the tumor, and that is what it is asked. They are so common that they comprises of 90%. 90%. Okay, because they are so common, they are most common benign and they are most common malignant. Usually they are bilateral. Usually they are bilateral. Is it okay? Okay. Okay. Now they are of 5 types depending on what is there in their ovarian mass. First type is serous. Second is mucinous. Third is Brenner. Brenner is usually solid. And on this, the bladder growth factor has acted. Okay. Fourth is endometrium. And here the endometrial growth factors are acted. And fifth is clear cell. That is what it is asked in exam. Clear cell is of which type? Epithelial, germ cell, or sex cord type. Okay. Question comes on clear cell. Clear cell. Classify the clear cell tumor. It is epithelial type. Okay. Out of this, the most common things are asked: benign, serous. Okay, even most common benign is serous and most common malignant is serous. That is how they ask you. Okay, that is how they ask you. The most common is, and in the option they will give you serous, mucinous, Brenner, endometrioma, dermoid, like this. Okay, most common of all is epithelial, and most common epithelial tumor is serous. Okay, even the most common malignant is also serous. Now, what is the age group in which epithelial ovarian tumor is found? It is 55 years. ठीक है, माता जी में मिलता है. It is found in old people, 55 years. Okay, next, germ cell tumor. Okay, germ cell tumor are usually found in 25 years, 0 to 25 years. It is found in young. So which is the most common tumor in young? Germ cell tumor. That is how they ask you. Germ cell tumor always occur in 25 years, 0 to 25 years, and it is most common in this group, and it is usually unilateral. Okay, will you remember it? Okay, now there are different type of, beta, because it is asked in exam. Clear cell is asked in exam. Because we remember the serous and mucinous, and in the exam they are asking clear cell. That is why I have marked. Okay, dysgerminoma is similar to the seminoma of the testes. Okay, and it is the most common malignant. It is the most common malignant, and it is the most common bilateral. Okay, it is the most common malignant and it is the most common bilateral. Okay, germ cell most common malignant is dysgerminoma, and germ cell most common benign is dermoid or benign teratoma. Benign teratoma, another name is mature teratoma. Don't confuse yourself in exam. Okay, benign teratoma, dermoid and mature teratoma, they are one and the same thing. Similarly is the immature teratoma. Okay, the another is endodermal sinus tumor or yolk sac tumor, and next is non-gestational trophoblastic neoplasia. Okay, so how you will remember? Dysgerminoma, you know that dysgerminoma comes from germ cell, primordial germ cell, you know that. Then from the germ cell what is made? Fetus is made, yolk sac is made, and placenta is made. Okay, fetal part forms teratoma, the yolk sac part forms endodermal sinus tumor, and the placenta part forms non-gestational trophoblastic neoplasia. Is it okay? Is it okay? The another type is stromal and sex cord tumor. Sex cord means the follicle. Ovarian follicle. Okay. So in the follicle there are two types of cell, granulosa cell and theca cell. Okay. So they belongs to that. And another is Sertoli and Leydig. Fibroma is put here because the stromal is also here in the classification. Okay, Sertoli, Dr. Isra, here are your hormonal tumors. Sertoli and Leydig cells, they produce large amount of testosterone and they makes the female male. They change the sex. So it is known as arenoblastoma. Okay. Fibroma is the fibroma makes the Meek syndrome. Okay. What is Meek syndrome? Pleural effusion, ascites and benign form of the fibroma. Okay. And benign form of the fibroma. Why there is pleural effusion and ascites and still we are saying it benign? Why it is so? Just a minute, let me take the call. Hello? नहीं लगेगा आधा घंटा. Yes, can you tell me why there is pleural effusion and ascites in a benign fibroma? Because fibrous is something protein. Fibrous is something protein. So when the benign tumor, it grows and becomes very large in size and it forms hypoproteinemia. There is hypoproteinemia. Due to hypoproteinemia, there is pleural effusion and ascites. Okay. If this tumor would have been malignant, then what would have happened? Can you tell me? It would not have grown so large in size to cause effusion and ascites. Okay. Very good. Now let us study the tumor marker. What is the tumor marker of epithelial cell? Serous epithelial tumor marker is CA125. The mucinous tumor marker is CEA. What you do wrong? You make the CA125 tumor marker of germ cell also. Okay. CA125 is only of serous. It is not of germ cell. Okay. What is the tumor marker of dysgerminoma? LDH. Okay. What is the tumor marker of benign or dermoid? No tumor marker. On ultrasound, we see 3 germ cell layers. Okay. On ultrasound, we see 3 germ cell layer products. Okay. Ectoderm. What is the ectoderm product? Hairs. What is the mesoderm product? Can you tell me? Thyroid. What is the endoderm product? Can you tell me? Come on, everybody. What is the endoderm product? Can you tell me? Teeth. Okay. Maxillary jawline. Okay. Yolk sac. Yolk sac tumor is also known as endodermal sinus tumor. Its tumor marker is alpha fetoprotein. Choriocarcinoma tumor marker you all know. HCG. What is another name of choriocarcinoma? Non-gestational trophoblastic neoplasia. What is the tumor marker of germ cell? Inhibin. What is the tumor marker of fibroma? It's effusion and ascites, or you can say it's now let's see cervical punch biopsy. Okay. How you will interpret the report? You have sent the report. Okay. You have sent the report. Okay. If on the report it comes to be pre-malignant. See, in the report, don't always think that it will be written cancer present or cancer absent. There can be pre-malignant lesion also written on the report. Okay. There can be pre-malignant lesions also written on the report. So, CA cervix punch biopsy report. If CIAN 2 and 3, they are the pre-malignant lesions. Okay. Then what you will do? Leap. And if it is invasive cancer, what you will do? Conization. What do you mean by invasive cancer? Whole the epithelium was involved and it has penetrated the basement membrane also. What does invasive cancer means? penetrated the basement membrane also. Now these are the steps you will take in the case of pre-malignant lesions. Okay, come on very fast. If squamous cell carcinoma is there, what you will do? Staging. Very good. You will do staging. Which is a clinical stage? It is a clinical staging. Okay, clinical staging. In the endometrial biopsy, what is the pre-malignant lesions? Come on everybody. It is hyperplasia with or without atypia. With atypia, how much risk? With atypia, how much risk? CIN can change into CA in 1%. CIN2 can change into CA in 5%. And CIN3 can change into CA cervix in 25%. The values are 1, 5 and 25. Is it okay? Okay. Endometrial biopsy. Endometrial biopsy, squamous cell hyperplasia without atypia. Okay, what is the treatment? What is the treatment for hyperplasia without atypia? Progesterone. Okay, if without atypia is there, you will give progesterone. If with atypia, you will do hysterectomy. Simple hyperplasia without atypia, how much chance? 1%. Complex hyperplasia without atypia, how much chance of becoming cancer? 3%. Simple hyperplasia with atypia, how much chance? 8%. Complex hyperplasia with atypia, how much chance? 30%. Okay. So this is the figure. For CIN 1, 2 and 3, the figures are 1, 5 and 25. And for the endometrium pre-malignant lesions, the figure is 1, 3, 8 and 30. Okay. If there is a report of an adenocarcinoma on the endometrial biopsy, if the reporting says adenocarcinoma, then what you will do? Surgical staging. Cancer has been diagnosed. Now we have to treat the patient. We will treat the patient as per its stage of cancer. Okay, staging will help us. Ovarian tumor marker have become positive. Okay, then what you will do? Surgical staging. Jai Shri Krishna Soni ji. What you will do in the case of ovarian tumor marker has come positive. For example, say alpha fetoprotein is positive. What you will do? You will do surgical staging. Okay, only the clinical staging is present in CA cervix. Otherwise, we do surgical staging. How we do surgical staging? Which is the surgery? Gestational trophoblastic neoplasia. GTN full form is gestational trophoblastic neoplasia. Okay. Surgical staging. How we do surgical staging? Which surgery we do? For the adenocarcinoma of the endometrium, we do hysterectomy and bilateral salpingo-oophorectomy. And for the patient of ovarian tumor, we do debulking. What do you understand by debulking? Remove the tumor as much you can remove. Remove the tumor as much you can remove. Okay, as much you can remove. Then we have to do 3 biopsies. One is the ascitic fluid. Another is the retroperitoneal lymph node. Third is the omentum. Let us finally do the staging. Okay. What is the staging of CA cervix? Come on. Stage 1 is limited to cervix. Okay. Stage 1 is limited to cervix. And if it is not visible from the eye, it is stage 1A. If not visible to eye, it is 1A. If it is visible to eye, it is 1B. What do you mean by not visible to eye? The lesion is less than 0.5 mm. Okay, less than 0.5 mm. And if the lesion is more than 5 mm, then it is visible to eye. For doing the further staging, very good. For doing the further staging, you have to now the stage 2 and 3 means, beta, we are doing CA cervix staging, beta. Okay, we will draw a circle. Okay, only you need to do the CA cervix staging. You can left the other two. Okay, because CA cervix is staged clinically. Okay, so if the for the CA cervix second stage and third stage, you will draw in the exam you will draw a shape like this and you will draw a circle. Inner 2 circle is 2A second stage. Outer 2 circle is third stage. Okay. So what is 2A? Upper 2/3 vagina. What is 2A? Upper 2/3 vagina. Vaginas are asked very much. Okay. What is 2B? 2B is parametrium. This area. Okay. 3A is lower 1/3 vagina. 3B is pelvic wall. 3C is this area. This area, pelvic wall. Okay. 3C is, come on everybody, para-aortic and pelvic lymph node. Okay. Para-aortic and pelvic lymph node. Very good. Stage 4A is bowel and bladder. Stage 4B is rest body including inguinal lymph node, because cervix does not drain into inguinal lymph node. So involvement of inguinal lymph node is a metastatic lesion. CA endometrium. What is mode of spread? CA cervix mode of spread is? Yes. CA cervix mode of spread is? What is meant by pelvic wall? Going above more than parametrium, not involving the genital parametrium besides uterus, going towards the pelvic wall parametrium. Okay, crossing the peritoneum of the uterus, crossing the peritoneum of the uterus. Okay, CA cervix mode of spread is lymphatics. CA endometrium direct. What do you mean by direct? Organ to organ spread. Organ to organ spread. Very good, Dr. Rakesh. Okay, so first is endometrium and myometrium. If endometrium and myometrium are involved, it is stage 1. Stage 2 is cervix, and stage 3 is stage 3A is serosa, and stage 4 is stage 3B is vagina. That is what it is asked. Okay, vagina involvement in endometrium is asked, and you have to remember 3C. Okay, rest is same as CA cervix. Rest is same as CA cervix. 3C, 4A, 4AB, 4B is same as CA cervix. So you need not to remember it. You have to remember 3B and 3A and 2A in CA cervix, because 2A is upper vagina and 3A is lower vagina, whereas involvement of vagina in CA endometrium is 3B. See here, involvement of CA cervix, upper vagina, it is 2A, lower vagina 3A, CA endometrium, vagina involvement 3B. You have to remember these three things. Let us have a superficial classification of CA ovary, limited to ovary. Limited to ovaries. Limited to ovary is stage 1, pelvic cavity. Stage 2, pelvic cavity includes uterus, bowel, bladder. Okay. Abdominal cavity. It includes ovary, stomach, liver, spleen. Stage 4 is metastasis. Okay. Now, when we have sent the ovarian biopsies, okay, there are two findings which are commonly asked in exam. We will not learn each and every finding. We will learn only the histopath finding of the ovarian tumor. Okay. Only two we have to learn here. Number 1 is York sac tumor or endodermal sinus tumor. What are the histopath finding? Schiller-Duval's body. Schiller-Duval body. S. Okay. Schiller-Duval bodies. How you will remember Schiller-Duval bodies? Here the empty spaces are outside. Empty spaces are outside. This blue color means empty spaces. Empty spaces are located outside. Okay. Whereas in the granulosa cell tumor, what is the histopath finding? Kohl-Exner bodies. Here the empty spaces are inner. Empty spaces are inner. Okay. Are inner to the collection of mass. Okay. And that is why they are known as flower shaped also. Flower like. So if the empty spaces are outside, it is sinuses. Empty spaces means sinuses are outside, it is Schiller-Duval. If the empty spaces are inside, it is flower, Kohl-Exner bodies. Let us see the treatment. CA cervix treatment in all stages is, come on everybody, last slide it is. Last slide, after this we will do questions. CA cervix, last slide. What is the treatment of CA cervix? In all the stages, it is chemoradiation, not only radiotherapy, chemoradiation. What do you mean by chemoradiation? If we will give chemotherapy before the radiation, then the radiosensitivity increases. But we don't prefer to give chemoradiation because of their side effect. Surgery is effective only up till 2A. Surgery is effective only up till 2A. So if it is after 2A, then only we will give the chemoradiation. We prefer the chemoradiation. Please don't mark in the exam radiotherapy. It will go wrong. Okay. Yes, cisplatin is given. Please don't mark in the exam radiotherapy alone, because radiotherapy alone is not given. Okay. Remember these three words, 2A, 1A and 1A. For CA cervix, surgery is the treatment up till 2A. For CA endometrium, surgery is the treatment up till 1A. And for CA ovary, the surgery is the treatment up till 1A. Okay? Is it okay? In CA cervix, surgery is the treatment up till 2A. After 2A, what we give? Chemoradiation. In CA endometrium, after 1A, what is the treatment? What is the treatment? In CA endometrium, radiotherapy. Radiotherapy, okay. And what is the treatment in CA ovary after 1A? Surgery is the treatment up till 1A. If on the staging it is more than 1A, then chemotherapy. Chemotherapy. Which ovarian tumor is radio resistant? Sorry. Which ovarian tumor is radio sensitive? Write down in the chat box. Dysgerminoma. Dysgerminoma. Which is this? What is this? Cusco-speculum. What is this? Cusco-speculum. It is used to retract the vagina for the pap smear. What is this? Write down in the CA cervix growth. This is CA cervix growth. Okay. This is CA cervix growth. What is this? Colposcope. What is this? Piples forceps. Used for taking the endometrial aspiration biopsy. Very good. Piple biopsy, not forceps. Piple, you can say cannula or aspiration biopsy taker. What is this? What is this? Dermoid or mature teratoma or what are the another name? Dermoid cyst, benign teratoma or mature teratoma. Which bodies are this? Which bodies are this? Which bodies are this? You can see the space is inside. Space is inside. If the space is inside, it is called exner bodies found in granulosa cell tumor. Okay. What is this? Here the space is outside. Okay, here the space is outside. This is Schiller-Duval bodies found in endodermal sinus or yolk sac tumor. What is this? What is this? Dysgerminoma histopath. Septas with lymphocytes. What is this? Air spatula. Air spatula. Very good. What is this? Coplin's jar. Coplin's dust. Okay. In this we put the pap smear slide. Do you want to do the questions? There are only 10 questions. Do you want to do? Yes, 15 minutes. लाइव लाइव चल रहा है, हमारी छुट्टियां 15 लाइव चल रहा है बेटे. चलो ओके चल रहा है. हाँ हाँ. Okay, start it. Which of the following is caused by low risk types? Come on, everybody. We will complete the questions fast. Which of the following is caused by low risk type? Be fast. These are the 15 expected questions. Laryngeal papillomatosis. Answer is laryngeal papillomatosis. The lady with warts was found to have HPV of high risk type. What is the type? Very good. What is the type? Lady was having the warts, but the virus is high risk type. What is the type? No, it is HPV 18. It is high risk type. Dr. Kavita, high risk types are which virus? 16, 18, yes, 31, 33, 45, 52, 58. Okay, these high risk type can cause cancer sometime, and the low risk type, high risk type can cause warts rarely. Okay, high risk types cancer causing can cause warts rarely, and the warts HPV 6 and 11 also can cause cancer rarely. True about vaccination is all except. Come on, everybody. True about vaccination is all except. Does not require further pap smear. They can be taken with other live viral vaccine, but they cannot be taken in pregnancy. Okay, not in pregnancy. Bivalent is less efficient. Yes, bivalent is less efficient because bivalent is only for the 2 type, and whereas quadrivalent administered on 0, 2 and 6 months. These days it is administered on 0, 1 and 6. Very good. True about transformation zone. What is transformation zone? Under the effect of estrogen at the time of puberty, under the effect of the estrogen, the endocervix comes out. Okay, this is endocervix, this is ectocervix. This endocervix comes out, pouts out. Okay, and soon this endocervix is covered by the epithelium of the ectocervix. The endocervix epithelium is, come on everybody, the endocervix epithelium is columnar. Ectocervix epithelium is squamous cell. When this pouted out, this pouted out endocervix is covered by squamous epithelium. So this zone is known as transformation zone because its epithelium has been changed. Okay, because its epithelium has been changed. Okay, do you got this? So this is the site of, this is the dynamic zone, this is the site of CA cervix. So whenever in the question they ask what is the site of CA cervix, you will say transformation zone. If transformation zone is not in the option, you will say squamocolumnar junction. If squamocolumnar junction is not in the option, then you will say ectocervix. But your first choice will be transformation zone because already metaplasia has occurred there. Okay, already metaplasia has occurred there. So more are the chances of dysplasia here. Okay, all is the answer. Which statement is not true about CA cervix screening guideline? Come on everybody. PAP is repeated yearly. PAP is repeated yearly. Visual inspection of acid is more reliable in old age because I told you PAP, first of all, PAP is repeated 3 yearly and HPV is repeated 5 yearly. Okay, HPV is repeated 5 yearly. Via is more reliable in old age. Why it is so? Because under the effect of estrogen, more endocervix pouts out by the old age. Okay, and the transformation zone becomes more clear. Okay, so the answer is not this. Okay, answer is this. PAP repeated yearly. Okay, because the pap smear is repeated 3 yearly and HPV DNA is repeated 5 yearly. Most common symptom of CA cervix. Most common symptom of CA cervix. Come on everybody fast. Irregular vaginal bleed. What is the most specific symptom? Postcoital bleeding. What is the answer? Here the patient has come with abdominal distension and pelvic pain. CA 125 is high. What is the answer? Ovarian tumor. Why? 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 Sometimes they confuse you by saying there is respiratory distress. Sometimes they confuse you by saying there is respiratory distress. Respiratory distress will always be present in abdominal mass. CA 125 is the tumor marker of ovarian tumor, beta. So answer is ovarian tumor. Okay, which tumor? CA 125 is raised. Which tumor? Serous. 60 years old lady with diabetes and hypertension presented with post-menstrual bleeding. What is the next step? Post-menstrual bleeding. You will do pap smear or colposcopy. The most common cause of postmenopausal in India is CA cervix. So you will of course screen CA cervix. You will do pap smear or colposcopy. Pap smear. Answer is pap smear. Why not colposcopy? Because it is not PMB, is not specific symptom. Okay, answer is pap smear because postmenopausal bleeding is not the specific symptom. Okay, her mother had 37 years old lady on oral contraceptive pills. Her mother had breast cancer at 55 and sister had ovarian cancer at 40. What is the next step? Genetic testing and BRCA testing. All are risk factor for the development of ovarian cancer except use of oral contraceptive pills. Clomiphene is there. History of BRCA mutation. Oral contraceptive pill protects. 52 years old lady present with post-menopausal bleeding. Cervical growth present. What you will do now? Now it becomes the symptom. What you will do now? Dr. Kavita, family history. Family history. Punch biopsy. Dr. Kavita, punch biopsy. Cervical growth is there. Okay. Punch biopsy. Now it is not only a case of post-menopausal bleeding. Cervical growth is present. Cervical growth means CA cervix. Okay. Dr. Shahrukh, okay. Which is not a germ cell tumor. Which is not a germ cell tumor. You will do colposcopy in only if you are not able to see the lesion. Yeah, confusive questions are asked usually. Okay, which is not a germ cell tumor. Not a germ cell tumor. Granulosa cell tumor. Granulosa cell tumor is a 6 cord or tumor. Very good. Left side ovarian tumor. HCG is 4. Alpha fetoprotein is normal. LDH is raised. Diagnosis. Come on, everybody. Very good. Diagnosis. Dysgerminoma. CIN3 on punch biopsy. What is the treatment? Punch biopsy is the confirmative test. What is the treatment? Come on. CIN3 on punch biopsy. You will do leap. If leap is not given in the option, let's say leap is not given, there is given simple hysterectomy or Verdines hysterectomy, then what will you give? What is the option? CIN1 you have to repeat after 6 months. Repeat biopsy after 6 months. Which biopsy you will do for CIN3? Simple or very good? We will do simple. Verdines is for CA cervix. Okay? Very good. 55 years, para 3, life 3, obese, hypertensive patient with postmenopausal bleeding. Cervical biopsy, there was nothing. And endometrial biopsy, there was complex hyperplasia without atypia. Treatment. It is without atypia. Since the family is for being protective, one can go, but guideline says repeat biopsy. Endometrial cancer with vaginal metastasis stages. Stage 3B. Endometrial cancer stage 1B treatment. Come on. After 1A. After 1A in the endometrial cancer, we do radiotherapy. Ovarian malignancy, all done except radiotherapy. Very good. They are radio resistant except dysgerminoma. 50, last question. 55 years old lady with CA cervix stage 3A treatment. Come on. Chemotherapy and brachytherapy. Thank you for joining. It's time to close the session. Please post your queries at the rate Dr. Rana. See you soon tomorrow with the new class. Thank you. Please like, share, subscribe my channel. It encourages me a lot and it supports